I want to start just by underscoring a couple of things at the outset. The first relates to the tagline that you see here: efficiency, effectiveness, equity, and experience, implications of integrated payments for healthcare. It's important to underscore that the nation falls substantially short on both of the dimensions here, that is the performance dimensions embodied in efficiency, effectiveness, equity, and experience, and on organizational dimensions, because we certainly are a system that is characterized by fragmentation, which is one of the major reasons, if not the major reason, that we're not able to deliver on performance. We have an opportunity now because the issues are fairly clear, and the administration is clearly committed to advancing progress toward care that delivers value and care that allows everyone to reach their full potential for health and well-being, and to identify specific actions that might be helpful in that respect. So we are very fortunate to have with us, and have had with us as well over the previous two sessions, individuals and groups who represent the best expertise in the nation in these issues and areas. And we're looking forward to taking advantage of that expertise and moving to the development of an action agenda. The objectives of the workshop series are essentially three. You see four listed here, but we're assuming the deficiencies are pretty well understood. So we've not dwelled on those issues. We've been focusing quite clearly in the first day on the vision that we seek of health financing that does improve efficiency, effectiveness, equity, and experience. On the levers in the second session that might be engaged in order to move the system toward the kind of performance that we all expect. And today on focusing on the strategy and the strategic actions that are necessary to move forward. I want to underscore the partnership that's been engaged in this work, partnership among many collaborators. The co-sponsors of the National Academy of Medicine. If I can go back to the previous slide. And if you look down on the left-hand side here, you see the Board on Healthcare Services and of the Health and Medicine Division at the National Academies of Sciences, Engineering, and Medicine. So we're very pleased to have this partnership in play, and thanks to our Board on Healthcare Services colleagues, and I believe Cheryl Nass is on the here in the meeting. She's the director of the board. I also want to pause here to give special thanks to Jennifer Flaubert and Jennifer Lee and Mike Cocciola, who have been, the two Jennifers have been the spearheads for this effort, and Mike has been a key player. And there are a number of others that we'll mention later on, but it's been a truly wonderfully staffed effort. Next slide, please. I, of course, have to give, with great pleasure, credit and thanks to our workshop sponsors, the George Family Foundation. We have Gail Ober here from the George Family Foundation. We have Kara Walker from the Nemours Foundation. We have Wayne Jonas from the Samueli Foundation, Benjamin Miller from the Wellbeing Trust, and James Marzolf from the Whole Health Institute. Thanks very much to each of our foundation colleagues and your associates for the sponsorship of this work and the partnership moving forward. Next slide, please. Of course, the entire enterprise has been organized by a terrific planning committee, many of whom you'll recognize from various venues. The co-chairs are Keisha Davis from Aledade, and Mai Pham, who's the president and CEO of the Institute for Exceptional Care. And joining them on the planning committee are Andy Beinman from the Kaiser Foundation Health Plan, Steve Cha, who was previously United Healthcare and now is in the Office of the Secretary at HHS, Margaret Chesney, who's Professor of Medicine at UCSF, Dina Chisholm, welcome back from vacation, Dina, who's the director for Center for Child Health Equity and Outcomes at Nationwide Children's Hospital, Chris Kohler, president of the Milbank Memorial Fund, Peter Long, Chief Healthcare Transformation and Affordability Officer from Blue Shield of California, Josh Sharfstein, Vice Dean and Professor at Hopkins School of Public Health, and Sarah Zanton, who's the Health Equity and Social Justice Endowed Professor at Johns Hopkins Nursing. A really terrific group of advisors for the effort who have, under the skilled leadership of co-chairs Davis and Pham, developed an extraordinary agenda. And so let me move straight away to the introduction of the agenda via my Pham and Keisha Davis. I do want to say that on the next slide, please. Here are your co-chairs. My Pham is as I mentioned, the president and CEO of the Institute for Exceptional Care, which is a nonprofit organization that is focused on transforming healthcare for people with intellectual and developmental disabilities. She previously served in a number of very important policy positions throughout the previous the Obama administration, serving as the Chief Innovation Officer at the CMS Innovation Center. And then she moved to Vice President at Anthem, where she made major contributions to the fields of payment policy and value-based care. And Dr. Keisha Davis is co-chair of the Planning Committee, as mentioned. She's a family physician, a community health advocate. She serves as Vice President of Health Equity at Aldaid, is a commissioner on MACPAC, and previously served as medical director of CHI Healthcare, and also as a White House fellow. So as I turn the floor over to Mai and Keisha, I want to again underscore our deep appreciation to both of them for a wonderful navigation in collaboration with committee colleagues of an agenda that will lead us to the kind of action necessary if we're going to take advantage of this unique, special, and very important moment to truly transform health financing in the nation. And I believe, Keisha, you're going to lead off. Is that correct?
Yes, thank you, Michael. And thank you, Michael, for your vision in setting this forward, and also to the staff and to my co-chair, my Pham, as we approach day 3. Thank you to everyone who's joining, those of you who have been with us already for day 1 and 2, and those of you who may be joining us for the first time. We appreciate you joining for this 3rd and final session of our series on financing that rewards better health and well-being. And as Michael alluded to, our previous 2 days have been not just insightful, but they also really spur us to action, which is one of the additional goals of this conference. So I want to do a little, reflection and read back, summarizing what's happened over the last couple days. So on day 1, we were really invited to dream big and reimagine how we think about and how we define financing whole person health. Day 1 was really about setting the vision. And in that, we were cautioned to recognize that healthcare is not the solution to every problem, but every problem is worse when whole person health is not financed appropriately. And while healthcare is not the only answer, its focus on patients' well-being provides a North Star and guide towards efficiency, effectiveness, equity, and experience, positive patient experiences. And we were reminded that fee-for-service is not the enemy and capitation is not a magic bullet. However, maintaining the status quo is untenable. It is expensive, and the friction that exists between insurers and providers in our current non-integrated system is costing us billions. Whole person health necessitates population health, and population health necessitates health equity, and health equity necessitates addressing structural racism, and addressing structural racism necessitates community engagement. And as we talk about health and equity, we need to make sure that we are including the voices of our children and our disability communities, and recognizing that the toll that the double pandemic of both physical and mental health that has occurred over the past year impacts them just as much, if not greater, and that ongoing investments in education, primary care, and mental and behavioral health are the key levers for improvements in health outcomes. We were challenged to push beyond small incremental changes and rather to take bold action to move us where we need to be. A year ago, that seemed impossible. But the COVID-19 pandemic has taught us that when push comes to shove, we can integrate systems, we can work with our competitors, we can aim for equity, we can put the best interests of our patients at the forefront, and we can find a way to pay for it. We concluded day one identifying critical opportunities for action, and in summarizing that, really redesigning payment to focus on a longer-term return on investment, incentivizing addressing social determinants of health, ensuring the ability to make infrastructure investments that promote a common infrastructure, data interoperability, and relationship building, and removing those barriers that make collaboration difficult to allow for increased efficiency and collaboration between systems, such that existed throughout the pandemic. On day two, we really focused on levers, the levers of change at the federal, state, and private levels. And in imagining new models, we should be prioritizing services that first are scalable and community employer collaborations and wraparounds that go beyond just point-to-point acute and institutional medical care coordination. And second, prioritizing primary preventive care, behavioral health care, and long-term services and supports, care that addresses equity, education, lifestyle, loneliness, and the pediatric determinants of social needs. The strategies to do this include prioritizing patient and family engagement, to create delightful healthcare experiences with trusting, culturally competent health relationships, investing in workforce, including community health workers and patient navigators to reduce clinical burdens and better identify patient community needs while providing jobs and human capital to the community. And in creating tech-driven, but not tech-focused infrastructures that better promote collaboration, patient and community engagement, and serve as a means of facilitating data sharing to benefit patients and communities and promote new innovations. And we learned of smarter community-informed payment models in states like Vermont, Maryland, and Washington, and the need to stop unsustainably bleeding old stones to pay for whole person health, and rather find new stones, new models that reduce waste and reallocate savings to high-value services and pay to incentivize better health outcomes, population health, and focus on the human condition. Ultimately, our most critical opportunities for action are to leverage the pandemic momentum to improve infrastructure for workforce, primary and preventive care, behavioral care, and innovative services such as telehealth and home and community-based care. Innovate in the current financial reality to advance whole person population health and well-being by determining the level of investment that's needed in social needs, and collectively act with a system-level focus rooted in a common cause to change the overall system through grassroots action. To push CMS to advance accountable health communities, not just organizations, accountable health communities, and move beyond small episodic waivers to pursue nationally scalable, globally budgeted, and innovation-supportive financing. And finally, state and federal legislatures should take and reinvest a portion of every delivery dollar back into the community to help support addressing social determinants of health. As we conclude days 1 and 2 and broach day 3 to really talk about the big vision, where do we go from here? How do we put this into action? So we have an excited panel ahead for you. I'm going to turn it over to co-chair Dr. Mai Pham, who will give you a preview of the events for today.
Thank you, Keisha. And before I get started on the outline for today, I did want to share a little bit of a summary about a related National Academy effort on payment reform and other ways that we need to act in order to address the primary care crisis in the country. And just wanted to share that for those of you who are interested, there are recordings of the first in a series of webinars to discuss and explore action steps following on this new NASM report on the NASM website. And to note that if we're talking about financing and payment mechanisms to support whole person health, it's really difficult to imagine what that vision looks like in execution without a core spine of effective primary care delivery underpinning it all. So strongly encourage you to look at that and to consider that the recommendations in that report are actually, in my opinion, quite bold, calling for policy actions that will, in all likelihood, meet with resistance from certain interests and stakeholders, but that the committee felt were really necessary to finally solve the problem of the workforce decline and the infrastructure decline, the underinvestment that we've made in primary care. So with that, let me turn to day 3. And I believe we were going to show, yes, thank you, the outline of the day. So we're going to have 2 panels and a set of closing remarks today. The first panel will be on transformation levers. And then we're going to have a third innovation spotlight where we profile or give the opportunity for a leader who is doing the work of supporting whole health on the ground in actual communities, describe to you their approach and what we can learn from that. The second panel will address how we can accelerate transformative financing approaches. And then we'll have a closeout session with a conversation between David Mullenstein, Vivian Lee, and Don Berwick, moderated by Keisha, to summarize what we think the arc of the conversation has been over the course of the workshop and the takeaways that we need to keep in mind as we move toward action. So with that, let me also just touch on something that we began the workshop with, which was introducing to you 3 archetypes of people before even they become patients who would really benefit from whole health. And we want to encourage you to keep them in mind as the conversation today evolves and ask yourselves, how do the actions, policy levers, the kinds of solutions that get named today and that we may find ways that we each want to advocate for, how will each of them impact these types of actual people? So Jamal is a 10-year-old boy with allergies, asthma, and ADHD. He's really good at soccer, but he can't always get his inhalers, and he's had to miss several games and practices. His primary care provider has recommended counseling and dietary supplements in addition to medication for his ADHD, but has found that his parents are hesitant to start medication and they can't afford the supplements. So this team has not been successful in finding a therapist that accepts their insurance and they can't afford to pay out of pocket. Margarita is a 45-year-old mother of 2. She works full-time as a private home duty care nurse, and she usually works at nights because she has to take care of her family during the day. She's also the primary caregiver for her parents, so she's in that sandwich generation, and her mother was recently diagnosed with Alzheimer's. She has a BMI of 33 and has pre-diabetes and mild hypertension among her cardiovascular risk factors. And her doctors recommended that she improve her diet, get more exercise, and also set a weight loss goal. But she's suffering from many other things her doctor is not addressing, like poor sleep and finding time to exercise. She has coverage through a high deductible insurance plan through her employer. And third is Mr. Chen, who's 85 years old and a widower. He lives alone with children who are in a neighboring county who get to see him weekly. He really, really wants to maintain his independence and has to rely mostly on frozen meals and his daughter has expressed concern that he may be losing weight. He has peripheral vascular disease and neuropathy and macular degeneration, which also limits his independence. He's never had fall risk in his home, but all of the recommendations that his doctor is making to try to improve his metabolic profile and gait training it has come to naught because he's had to cancel many appointments. So as you think about these archetypes, we would also encourage you to read between the lines here and think about what the underlying challenges really are for these patients and their families. In the case of Jamal, it may be the combination of stressed parents who now may be missing hours of work and worried about those outcomes in their lives as well. For Margarita, it seems to be that she is simply not making the kind of income that she needs to meet basic needs for her family and stretching herself again under terrific stress to care for 2 generations in her family. And for Mr. Chen, the theme here is loneliness and a rather desperate desire to cling to his independence without a clear path or guarantee that he can have that. So with those touchstones, let's turn to just a few housekeeping items before I turn it over to the first panel. First of all, we'd encourage all participants to use the chat function to add any comments or questions. The moderator for each panel will turn to some of those and pull from them during the discussion. And also want to highlight that we are recording the workshop, and a copy of both the slides and the recordings will be available to view after the event.